Hi, I'm John Tazi from Bloomberg News, and I'm happy to be here with Dr. Shannon Dowler, the Chief Medical Officer for the North Carolina Medicaid program. We're going to talk about telehealth and innovations in reimbursement today. But before we get into the panel, Shannon, can you just give a brief introduction to yourself and your role at North Carolina?
Yeah, so I'm Shannon Dowler. I'm a Chief Medical Officer for North Carolina Medicaid. I'm a family physician by background, and I live in Western North Carolina up in the Appalachian Mountains.
Great. So I know the audience has already seen your presentation, really informative. I'd love to hear, you described a situation in North Carolina where telehealth was very limited in the Medicaid program prior to COVID, and then this rapid expansion when the pandemic hit. Can you talk about, prior to COVID, what were some of the barriers to greater telehealth use in North Carolina Medicaid?
Sure, John. So in December of last year, only a few months after I joined the Medicaid team, I, along with one of the assistant secretaries for Health and Human Services, launched a telehealth modernization team to start doing it. And in our work and studying what was happening in other states and where we wanted to go, our sort of aspirations, we projected a 3-year timeline to be able to make it to where we wanted to go, which was not everything we wanted, but what we felt like we could achieve. Because of authority issues, funding issues, legislative and federal authority, there's all sorts of challenges sometimes when you work within a public payer program. And so we figured it would take us 3 years to get through it. At that time, less than 0.1 of 1% of our total weekly claims were in telehealth because we only had a consultative model. So it was extremely limited utilization, really mostly in the psychiatry space.
Got it. Now, I know you described sort of accelerating that 3-year expected time frame into a period of was it 7 weeks? Is that right?
Yes.
And can you just talk briefly about sort of what some of the kind of challenges of that transformation were?
Yeah, I think so I'm still relatively new to a Medicaid program. I'm just a year in. But early on, I learned that policy changes take a while. You've got to go through a state plan amendment sometimes, and the fiscal analysis, and looking at state politics and how they play into your plan. And so usually, if I have a new policy, it was like a 9-month time period from the time I wanted to implement it to when I could feel reasonably good that it had gone through all the hoops and was going to go live. So instead, every week we turn on a whole nother set of changes, clinical policy changes, because the field needed it. Frankly, we were so far behind in North Carolina when we had the pandemic that we had to rapidly motivate everybody. The team was working, around the clock to make these changes because we didn't have a choice. We had people around the state that needed access to healthcare, and we had practices who had never used telehealth. Our prior model didn't allow FQHCs or rural health centers to be a distant site. We didn't allow patients to do it from the home. So there were all sorts of ways that we had to rapidly modify. And I will just say it took an amazing team of historical experts, folks that have been around the Medicaid team for a long, long time, as well as newcomers to sort of poke and prod and to drive the process and say, just because we haven't done it in the past doesn't mean we can't do it now. We've got to land this.
In your presentation, you talked about all these new flexibilities that you implemented, including many having to do with telehealth, affecting potentially hundreds of billing codes. Now that we're sort of, almost 6 months out from, I guess, the beginning of that transformation, what are some of the types of care that are best suited to telehealth that you're looking to make permanent? And what are some types of care that maybe should be shifted back to in-person care when it's safer to do so?
Yeah, that's a great question. And that we started back in May with the process of how do we unwind it? Once the genie's out of the bottle, how do we get the genie back in the bottle? And knowing that would be challenging. Also knowing that a lot of the provisions were things we wanted to keep. They were things we were going to do anyway. So let's, take advantage of the fact that we had to turn them on so quickly and keep them in place. And we really studied our utilization patterns. We were looking at outcomes, total cost of care, a variety of things. Also looking at federal guidelines and nationally, is there any evidence base for some of the modalities that felt a little more uncomfortable for us? I will tell you the areas that we continue to wrestle with that we haven't landed the plane yet on. Group therapy. That's one of the ones that is a tough area. It has some real benefits, but when you're talking about sensitive behavioral health topics, you can't necessarily safeguard everyone's privacy that's in a group session. And is that on the impetus of the Medicaid program to ensure that that's done, or is it on the provider who does it? And so we get into some of those challenging times. I think also the specialized therapies has been an area we've really wrestled with, things that historically felt very intuitive that no way we would do that by telehealth. And now we're saying, an example of that, speech therapy. We saw a tremendous amount of speech therapy utilization, particularly in school-age children. And it seems to be very effective and good, and the evaluations, the qualitative analyses are suggesting that it's been a really good experience. But then you have to think about the things that require hands-on touch. And some of those things, particularly when you think about the physical therapy and the occupational therapy, there's certain things that we're still wrestling with. Can that service be provided by telehealth in a way that really gives the benefit, the maximal medical benefit to the patient? And we're looking still to feel out what's happening in the field, and is there any good evidence base behind some of these things that are a little more difficult. But I think whenever there's something that requires hands-on touch, a physical exam that's critical, or something that has a risk of being a high need, a patient with chest pain, shortness of breath, the things that might lead to a life-threatening or life-limiting outcome in the very near future, probably isn't best served by telehealth. So that is one of the challenges that I've heard from my colleagues around the state, that they'll get a telehealth visit on their schedule and it'll say chest pain, and they're like, no, we can't do that by telehealth. So I think everyone's learning those things.
Got it. And so that process of evaluating like what should stick around and what should maybe revert is still kind of ongoing in North Carolina?
Yeah, we have 3 phases of it. So we developed a process we called the circuit breaker, and it's really about, it took us 7 weeks to turn on all these emergency provisions. But next time we have a pandemic or some major crisis that affects the whole state, we want there to be like one big switch we flip. These are turned on, so the field knows exactly what to expect. And so we're working through that process now. Phase 1 was sort of the no-brainer things that everybody else was already doing and we were behind the ball on. Phase 2 is some of those special modalities. Lactation services is a great one. Why not do breastfeeding support to a new mom who maybe just had a C-section 5 days ago, and getting in a car and driving across town to an appointment would be really, really difficult? Why not do breastfeeding consultation through telehealth if it works for them? So we're looking at some of those: diabetes educators, tobacco cessation, how we use our federally qualified health centers. And then the third round is those that we're still sort of working through, those specialized therapies, audiology, optometry. Where is the place for that in a virtual visit? Got it.
Let's talk about reimbursement. How should reimbursement for telehealth services be calibrated relative to payment for in-person visits?
Yeah, it's a great question. And I really struggled personally early on in the pandemic when a lot of payers said, we're going to pay the same for face-to-face as telehealth as telephonic, because I felt it set us up for not a great expectation and for the future. And in fact, I don't think telephonic services are as thorough or as good as telehealth. And in some situations, not all, some situations, telehealth's not as good as in person. So I think when we're looking at an E&M coding world that we live in, the complexity of the visit, you're probably going to be able to document a much more complex visit in person because you're doing physical exam and vital signs and those sort of things. But having parity for telehealth and in person makes sense as long as the complexity of the visit and what is documented based on the guidelines is appropriate. I don't think telephonic's equivalent. I think it's an area that is risky for a variety of reasons. And while there is a place for it, I don't doubt that there's a place for it. It's not on a parity scale with telehealth and in person. I also think that we've just got to get away from this sort of perverse incentive of volume, and get into the value game. And that is really around how do we capitate, do prospective payments for primary care? What are the other creative things we can do so we're not worried about that?
Got it. And you guys are obviously anticipating a managed care transformation in the Medicaid program in North Carolina. I know there's been a lot of attention and excitement around this. It's kind of gotten some national coverage for the sort of innovative design and some of the things you're piloting. So talk about, kind of what telehealth looks like in a managed care environment for Medicaid. What role do you see it playing?
Yeah, so we're making some amendments to our contracts now. One of the agreements we had with the plans with managed care is that our existing Medicaid policies were the floor. So they had to at least meet what we're doing now as far as scope and duration and amount. So that includes telehealth. So they're having to add some telehealth provisions as we make things permanent that we think are really important. I think there's also one of the risks potentially is sometimes in managed care, there will be a sort of nameless, faceless teledoc who does some of the care that's not in their medical home. I don't think that's ideal. I think a lot of the strength of the telehealth visit is when it's with an existing caregiver who knows the patient's medicines, who knows their comorbidities, who ideally is in an EMR that can see what the specialists are saying and doing and has access to more information than the one-offs. One-offs have a place for, simple things, poison ivy. There's some basic things that I think I'm okay with it being outside the medical home. But I think to do telehealth really well, to really decrease total cost of care and improve outcomes, it's going to need to be in that medical home environment.
I was going to ask about that because I think, in the commercial world, certainly many of us have this experience where there's a telehealth option from the health plan and then maybe a telehealth option from a provider organization. And, particularly if you're not in a kind of existing relationship with any particular primary care provider, it can be hard to know if you have an acute need, who to go to. And this kind of potential, just sort of dual tracks, right? With, and ambiguity over who sort of controls a telehealth relationship with a member, with a patient for any given encounter or for a kind of longer term relationship. So it sounds like your preference for the managed care population in North Carolina is that a lot of that would kind of live within the sort of medical home and their existing primary care clinicians.
Yeah, I think that's the ideal case. And maybe we in the healthcare field need to be more creative in how we provide after hours and alternative ways to seek care that meets our patients' needs. And I think that's happened really rapidly in the pandemic. We still have the struggle, though. North Carolina is a rural state. And so there's the big digital divide of who has access to these services and who doesn't, and how do we get them? So broadband access is a great example of that. For the last 20 years, I've been in Western North Carolina for 20 years, which is in the Appalachian Mountains, beautiful place. Come visit after the pandemic. We decided.
We're just talking about the access to rural broadband and difficulties in Western North Carolina. So you dropped out right on cue, Shannon. But I don't know if you want to just briefly kind of finish that thought. And then we've got some questions from the audience that we can take in the last few minutes here.
Sure. Yeah, just that not every Medicaid beneficiary in North Carolina has access to broadband. And even if they have access to broadband, they may not be able to afford it. And so it costs twice as much for me living in a rural community to have a tenth of the broadband as I had in an urban community. And so that's a real issue when people have limited finances, as we see in our Medicaid program. But what I will say is that we have seen the doctors across North Carolina do amazing things to work around the issue and to come up with creative ways to share their Wi-Fi from their offices and their parking lot with patients, doing telehealth visits from a patient's car, using an iPad that the practice hands into the car, all sorts of creative ways to get care to the patients.
Got it. So one of the questions that came in was about incentives for providers. How do you incentivize providers to take patients with higher acuity in a capitated model?
Oh, wow. That's a big question. And I think the best way is that It's risk adjustment. You have to risk adjust their population, and so that their per member per month or their capitation is directly related to the population that they're serving. I think one of the hardest things is some of our most disengaged members end up being highest cost because they get engaged at the wrong time. And so how do you, so they're cheap, quote unquote, for a primary care provider because they never show up. So they get a PM and they never see the patient, but they cost the system overall. So how do we incentivize practices to take the patients that may be more work to engage in care, but maybe we use some of these modalities of engaging them so they don't have to leave the house, and we provide some resources for them to incentivize their care. I think there are a lot of ways, but risk adjustment is probably the main way to level set the field.
Got it. We have another question about kind of quality measures. North Carolina Medicaid is still fee-for-service. What are some of the qualitative measures that demonstrate value of the utilization of telehealth services for Medicaid patients?
That's a great question. So we are, for a few more months, fee-for-service. We're scheduled to launch in managed care in July. We are actually doing our survey, our member beneficiary survey this year. We've added a whole section on telehealth experience for that qualitative, to really understand what the beneficiary's experience is. We're also studying it as the impact on race and ethnicity and age and other things. And we're recognizing some problems, like a lot of the telehealth invitations are in English. And if English is not your first language, it's very difficult for you to navigate a platform. So we're working with our practice supports and others to provide training in the practices. But we are doing a special telehealth survey for our beneficiaries this year.
Got it. And another question that came in, can you speak to the number of, I think I have the acronym right here, but long-term care, home and community-based service waivers that were impacted by these telehealth changes?
Oh gosh, quite a few. That area is not an area I'm expert in. And so I've got a whole team that works on that, but quite a few. We made a lot of temporary provisions to home and community-based services in the pandemic. And those are some of the ones that we're really kind of wrestling with. And we've used a bottom-up process for our teams, our subject matter experts, to bring to the leadership team their recommendations for what should stay on after the pandemic. That goes to the executive team. And so far what we found is the executive team has approved or even expanded what the SMEs, the subject matter experts, want to cover. So I think that's been a real win of the way we've analyzed what stays on, what stays off. It wasn't a top-down process. It was very bottom-up. So from those very providers that are working with our Medicaid team, understanding the pain points and what's working and not working, and then they're making recommendations to what to continue.
Got it. I had a question I wanted to follow up on from something in your presentation. You kind of talked a little bit about this idea of a hybrid visit. And I'm wondering if you can kind of just elaborate on, what that actually is, what it looks like, and the role that you see that playing going forward. Because I think the entire healthcare system in this pandemic world is trying to sort of figure out what is the right mix, right, of in-person, at home, virtual, care. So what is a hybrid visit, and what do you expect it to, how do you expect it to play a role in the future?
Yeah, so we took what is a traditional home health visit where a provider goes into a patient's home, and there's a higher reimbursement associated with that. Even so, a practice loses a ton of money. So when I would go do a home visit with a patient who might be at an end of life or just has other issues that they can't get out of the home, I love doing home visits because you learn a lot about your patients, but I'd have to block 2 or 3 hours of my schedule because nobody lived a block away from the clinic, so you have to get there and do the visit. It always takes 3 times longer because you got to meet their dogs. And, it's a much more personal sort of experience. So it was, even with the higher reimbursement rate, it did not make sense. You lose access for provider time, and it's not cost effective either. So what we did with a hybrid visit is we created it so a trusted staff member can go into the home instead of the provider, facilitate that telehealth visit so the provider is seeing the patient while that trusted staff member is in the home. But that staff member could be doing immunizations or drawing blood or doing a diabetic foot exam or doing an NST if it's a pregnant woman. It allows that home health visit from a physician standpoint to occur with a much lower reimbursed trusted staff member that would be doing that same work in the office. but it allows them to go into the patient's home and then coordinate the telehealth visit. So it's a really high-value telehealth visit with hands-on gap closing things happening in the home.
Got it. And we have another question that came in. I think we're just about out of time, but I think we can run a couple minutes over. The question is about the sort of difference between a telephonic visit and a telehealth visit. How is telehealth defined? Is it interactive audio, video? Does it need to include remote patient monitoring? Sort of what's the distinction between those kind of types of visits?
Great question. So in our definition, we called it virtual health, which was telephonic or portal communication, or not, and then telehealth, which is that real-time two-way audio-visual communication. And that was how we separated those out.
Got it. Thanks. I think we're just about out of time. Dr. Dowler, anything else that you want to add as kind of closing remarks?
Just that I appreciate being involved in this and getting to share our experience in North Carolina. We're continuing to study our outcomes and to look at things like total cost of care and value to see what telehealth and telephonic and some of these other modalities have brought to the state. It's the one really great thing that's come out of a difficult pandemic is that we were able to rapidly modernize our telehealth.
Great. Well, thank you so much for your time, Dr. Dowler, and we'll all be watching to see what happens.
Awesome. Thanks so much.
Okay. Take care.